Okay, we're going to do a lecture on grief right now. Let me just get this set up as best I can. Let's see if we can do this. I think we're in pretty good shape here. Okay. Well, I got rid of Mortimer. And I got myself a Sigmund Freud. So there's Sigmund Freud. And after all this stress, I need therapy. So I bought a little finger doll of Sigmund Freud. Okay, back to reality here, folks. So today we're doing grief, loss, and bereavement. I realize it's not on the schedule. I apologize for that. Getting organized this past semester break was a little bit difficult for me. Let's go on here. Key terms here. Cathecting is an emotional attachment to anything. Many times it's people that we love, but it could be a car. It could be if you collect cameras or stamps or bicycles. Decathecting is breaking that emotional bond. The quicker you break that emotional bond, the quicker you decathect, chances are the more grief you're going to feel. Bereavement is the same as grief. Thanatology is the study of death and dying. And I want to include here affective denial. We usually think of denial as a negative thing, denying reality. But in this case, denial can be effective. When the loss comes on so quickly, people need to deny it to give their brains, their minds time to adjust to the new reality. So again, denial many times, particularly in substance abuse, we consider a negative thing. But in this case, affective denial buys the person time to readjust to this new reality. If they are going on denying for many, many months afterwards, that is not effective. So affective denial might only last a couple of weeks. Grief, an act of mourning any loss, emotional aspect of decathecting. It's classified as axis 4. I think I've gone over the axi already. It is a normal human emotion related to loss. Symptoms similar to depression, but have an abrupt onset and a shorter duration. Generally speaking, of course. Should not involve a loss of self-esteem. So grief, the symptoms of acute grief and the symptoms of depression are very, very similar. Fatigue, not feeling well, things like that. The difference being here is that with normal grief, a person should not be losing self-esteem. Now, there's a type of grief called complicated or dysfunctional grief, which we'll see in a few slides, where the grief morphs into depression. Unless grieving the loss in a breakup where grief and depression could both be experienced. And I say that because a breakup with a significant other, if they broke up with you, is a direct rejection of who you are. So breakups can lead to certainly grief and probably more easily lead to depression in vulnerable individuals. Once again, if you have a previous mental disorder, it's going to possibly be harder for you to adjust to grief. All patients in the hospital and nursing home are grieving some type of loss. I ask, what losses are they grieving? Well, just think about that. You get admitted to a hospital, you've lost your health. Chances are you're very seriously ill, otherwise you'd be treated as an outpatient. So you've lost your health, you've lost your sense of purpose, going to work, raising your children. You've lost your intimate partner, they're at home. You've lost your leisure activities. You've lost your hobbies. Again, those are the 4 areas that I have noticed in my career that we need, my little theory I've talked to you about. And not only do you lose all them, but you lose autonomy. You don't get to choose when you eat. You might not get to choose what you eat. You lose your privacy. So people in the hospital are all grieving to some extent. Manifestations of acute grief. Physical and physiologic. Again, very similar to depression. Fatigue, weakness, shortness of breath, headaches, anorexia, GI upset and disturbances, nausea and vomiting, decreased immune system. Let's talk about cognitive. Obsessions with object of loss. What could have been? And I think if you've watched the movie I'm Still Here, The Truth About Schizophrenia, One of the fathers in the movie, the father of the daughter who attempted to commit suicide at Arizona State University, father, you see him crying with his son, says, I have to change what I wanted my daughter's life to be. We all have dreams of our children getting married, going to college, or getting a good job, having a wonderful life. When someone gets ill like this, in this case, schizophrenia, the parents are truly grieving because all the dreams they had are now put on hold, at least on hold. Regrets, if only I had been nicer, kissed him or her goodbye, didn't leave him alone. So they may talk about regrets. They may ruminate, think this over and over and over. And again, rumination is a symptom of depression. People think things over and over. Inability to concentrate, confusion, changes in the way one views the world. So when you lose a child, a parent's a little different. An older parent's a little different because we're expecting that it's going to eventually happen, right? But if you lose a child, it may radically change the way you view the world because now the world doesn't seem fair. Maybe you were going to church, a certain religion, and the religion can't explain why this person died and not someone else. So it can really alter the way one views the world. Emotional, again, this is affective. Certainly anger, sadness, anxiety, guilt, possible depression if unresolved or complicating factors. So again, people that are prone to depression probably have a more difficult time with grief. This can result in self-medication, fighting crime. And again, when I say self-medication, I mean substance abuse. And once again, substance abuse is considered self-medication for anxiety, depression, childhood trauma, things like that. Behavioral, crying, certainly. When people are grieving, they're crying. And I like to think of crying think of it as emotional bleeding. When a patient is bleeding, a med-surg nurse does not walk away. They go and find out, why is this person bleeding? If you're working with a patient and they're crying, we want to find out what's going on. We just don't walk away. We want to find out, why are they upset? Okay. Agitation, pacing, restlessness, possible hostility toward others where they're projecting this anger at what's going on loved ones around them. Possibly an inability to mobilize. And this is really the pathological part here. People can be in grief, and grief itself is not pathological. As long as they're slowly climbing out of it, that's a normal trajectory. If they're staying in grief, unable to mobilize, that becomes more pathological. They can feel like they're functioning automatically, and this is depersonalization. So they feel like that it's not them, depersonalization. What types of grief? Anticipatory. This is mourning a loss before it occurs. You know this loss is going to happen. You're preparing yourself for it. As many of you know, my father passed away this past summer. My dad was 93, almost 94. And over the last 4 years or so, my siblings and I, we saw this coming. And we'd ask each other, are you ready for this, Eileen? Are you ready for this, Patricia? And we all pretty much were ready for it because it was a very gradual onset. Okay, so we could be grieving anticipatory. Acute, grief immediately after a loss. So this is the act of grieving right after the loss. Dysfunctional grief, which I mentioned a few minutes ago, is acute grief symptoms, non-remitting for 2 to 6 months. So again, someone dies, you're grieving over a couple of weeks or maybe a month and a half. You're climbing out of it slowly. You're going back to work. You're kind of getting back in your groove. But if you can't mobilize and get back in your groove after 2 months or 6 months, we call this dysfunctional grief. And it's bordering on depression, or it could lead to a full-blown depression. Because remember, people can be prone to depression. Disenfranchised grief. This is grief that cannot be shared. People, I'll tell you a story here. I was working doing private duty nursing, and this man had cancer. He was admitted to the hospital. I got a phone call And the woman said, "Is there a person with long brown hair there?" That was his wife, long brown hair. And I said, "No." And this woman said, "I will be right there." She came in. She had short brown hair, kissed him, said her goodbyes, whatever. She left. I get a phone call. "Is there a woman with short brown hair there?" And I said, "No." And his wife came in to visit him. Now, I'm not judging. We don't judge as nurses. This person may have been having some kind of relationship with this other woman. This other woman, who does she speak to? It could be a man too, but I'm saying it's a woman now. Who does she speak to? Our society does not accept the extramarital affairs. So that would be disenfranchised grief. She is unable to talk about it and share her grief with others. So I pose to you a question now. Who could this person go to who would accept this extramarital relationship? And this is where a therapist comes in. Remember, mental health professionals don't judge. We are neutral. We minister, in a sense, to all of humanity, no matter what. I've often said, nurses, we see the raw side of humanity. Humanity looks so neat and pretty from the outside, but when you delve deeper, things are not as pretty as they might appear. And many mental health professionals deal with the traumas that I'm talking about. So disenfranchised grief means grief that you cannot share with someone else because they'll reject you. So now you have to hold this grief in and you can't express it. That could lead to a dysfunctional grief. Grieving theorists. There are many, many grieving theorists. I looked through your book, Vedabek, and there's many theorists. We're going to stick with the big one, Kubler-Ross. She studied thanatology, which is death and dying. She described 5 stages that both the dying person and the loved ones go through. So it's not the dying person that's going through these stages. It's the people around that love this person who is dying. The first stage here is denial. Initially respond with disbelief, as evidenced by, "You must be making a mistake. You have the wrong patient. My husband did not die. It's not true. You're making a mistake." So rigorous denial. Again, effective denial gives us time for the psyche to adapt and deal with this trauma. Okay, so denial in this case can be effective provided it doesn't go on too long, provided they eventually accept the reality of the situation. Ineffective denial immobilizes the person. Okay, so effective is good, but ineffective would be where they're not moving on. Second phase here, anger at death or diagnosis. Okay, so they're angry that they're dying, or the spouse of this person who's dying is angry, or angry at the diagnosis, and they may project this anger onto the members of the healthcare team, especially nurses, because nurses are there 24/7. These people, no one in the hospital is happy. Everybody's grieving. We can't expect people in a hospital to be happy. They're going to be angry. They're going to be upset. They may project that onto us. Now, in a sense, we have to expect that. And in another sense, we might even look at it as this person feels so comfortable with us that they can express their inner emotions to us. In other words, they're not afraid of us. In a sense, that's a compliment to us, that our patients don't fear us, and they should never fear their caregivers, right? Now, I'm not saying be abused here, but expect that we may be the target of anger. Healthcare providers must not take this anger personally. Healthcare providers should help patient refocus feeling onto the fears that underlie the anger. Again, when they're ready, not right away. When people are in this, this anger, they're not ready to talk about the worries of the future since their husband is going to be, passing away. They're going to lose money and coming into the household, things like that. But maybe as things settle down, we can talk about how their life is going to have to readjust. Okay. Loneliness, loss of control, things like that. Third stage here is bargaining. Patient or loved one attempts to bargain with God, as evidenced by, "God, I will be a better father if you just let me live." God, let my son live and I will be a better parent. Okay, so they're bargaining, trying to find a way out of this desperately. Most people do this with any loss, that you bargain to try to help, bargain with God to have this person live longer. Fourth stage here is depression. Depressive symptomatology as reality of diagnosis and loss sets in. So now the reality is setting in. They're getting sad now. They're having depressive symptoms, okay? Anticipating grieving of job, upcoming financial hardships, isolation from friends. What is life going to be like without my significant other or without my child? This is the real core of the grieving process. And this can be treated with interventions for classic depression. In other words, we could treat this person with medication, but the question is, should we? If we give somebody medication prematurely, they may not work through the grief process because the antidepressant, usually elevating serotonin, makes them feel better. So they might not work through the grief. So our job would be, or a prescriber's job would be, at what point do we give this person medicine? We want them to grieve. We don't want to prevent them from grieving. But on the other hand, we don't want them to suffer unnecessarily and possibly get solidified in a stage of grief of maybe anger or depression and unable to get out of it. Okay? So medications can be used here only if the person is not mobilizing and is getting stuck in one of the phases of grief. Fifth stage, acceptance. Patient or loved one accepts inevitability of diagnosis and death, as evidenced by decreased anger and decreased depression, ability to talk about and plan for death, ability to enjoy the time that is left. So the person here accepts the fact that they're going to die, and they may say to their significant other, let's go on a cruise. Let's have some fun. Let's go do things. In other words, they've accepted it. Now, not everybody gets to this stage. So the stages of grief, not everybody goes through all of them. People can jump stages, people can go back a stage, or people can get stuck in a stage. And that stage could be denial, it could be anger. In fact, I knew a family when I grew up, their son was killed in a car accident, and the mother, 5, 6, 7, 8 years down the road, never went into her son's room, left her son's room exactly as it was when he was killed 5 or 6 years prior. They're not moving on, they're stuck there. Let's talk about unexpected and unexplainable loss. Loss, especially if unexpected and overwhelming, can radically alter a person's view of the world and life path. When something is so unexpected, it can just blow someone away psychologically and really change the way they view the world. Person can become bitter if unable to resolve the grief. Person can focus energies toward helping others or righting a wrong. So in this case, the person can take that angst from grief and convert it to something productive. And this is exactly what MAD and SAD is. MAD is Mothers Against Drunk Driving. SAD is Students Against Drunk Driving. These are students or parents and mothers who lost children in DWIs, who have tremendous grief, but turn it in a way and take that energy to convert it to something constructive. This is positive. This can happen with any grief, any loss, right? But when it's unexpected and you lose your son or your daughter in a drunk driving accident, to take that anger and that angst and convert it to something productive is mentally healthy. Let's talk about the nursing process here. What do we do as nurses? First, we have to assess to get data, right? We assess the intensity of the grief. What phase of grief is the person in? And again, when all of mental health care, the first thing we do is ask about suicidal ideation. Mr. So-and-so or Mrs. So-and-so, do you have a plan of hurting yourself or committing suicide? If they say yes, we ask about a plan. The more elaborate the plan, the more they've thought about it, which means they put energy into planning this. That is very serious. They probably need to be admitted to a hospital. We also want to assess social supports. Certainly, the more the better. The more you're held up in a fabric of socialization, the less you're going to fall out of that fabric and go into a depression. I've said it before. Humans are the most social animals on the face of the earth. Again, we know that because we all have cell phones. And we all are held up in a fabric of human connectedness. Mental disorders, physical disorders, severe physical disorders, prevent us from engaging in socialization with other humans. Okay. Premorbid functioning, in other words, morbid is the event. Before the event, how is they functioning? Probably the best predictor of successful grieving. If they have a lot of friends and they had a job that they enjoyed and they had children, they were feeling good about life, they're probably going to do better who's someone who had depression already or who had an alcohol problem, things like that. Okay? Ability to mobilize. Is patient able to carry on? We want to assess that. Again, we don't expect them to get out of grief in a week. Okay? It might take weeks or months, but as long as they're slowly climbing back up to their premorbid level of functioning. We want to assess the propensity for substance abuse. Okay, that makes things worse. Again, alcohol by nature is a depressant, as we've said. Cocaine is a stimulant, but when you come off it, again, the opposite is true. You're going to be more depressed. So substance abuse is not healthy at all. Nursing diagnosis. If grieving and mobilizing, there's probably no diagnosis. Why? Because grief itself is not pathological. It shows love for a lost object. If having extreme grief reaction, nursing diagnosis will vary depending upon the presenting signs and symptoms. So there could be multiple diagnoses here: anxiety, a fear of death, things like that. And there's a list of them: impaired adjustment, anxiety, death anxiety, confusion, ineffective coping, i.e. substance abuse, ineffective denial, anticipatory or dysfunctional grieving, hopelessness, disturbed personal identity, especially in older couples who have been married a long time. In yesteryear, many years ago, 50, 60, 70 years ago, people got married quite young. They might have been married at the age of 21, 22, maybe even 19. They live with their spouse for 60 or 70 years, and the spouse passes away. They may never have developed the ability to live alone. So it's going to be more difficult, as opposed to somebody who gets married at 35 who's lived alone, married to the spouse 40 years, they pass on. They know they can do it. They've done it before in their life. So when someone has been married so long and then their significant other passes away, they can have a disturbed personal identity. Who are they without their significant other? Certainly risk for loneliness, self-care deficit, and that could really happen with a dysfunctional grief that's leading to a depression where the person can't even get out of bed to do self-care. Outcomes. Again, the outcome is usually opposite the data, because the data is what got us to our diagnosis. We want to get rid of the data so we can get rid of the diagnosis. Patient will have decrease in symptoms of grief. In this case, nursing interventions should assist patient in healthy grieving. We want to validate feelings of loss for this patient. Something like, yes, I can see, losing your father is so difficult. It's quite difficult. Again, losing a father at 93 might be much different than losing a father at 50 years old. Okay, because we expect someone to live longer than 50 years. We can educate this person that grief is normal and demonstrates love for the lost object or person. Again, I say object because you could have a beautiful car that you love, an antique car that gets wrecked, and you can grieve that. That's not a person, that's an object. Okay? So grief shows that you loved. And I heard a great quote. Loneliness is evidence of the ability to love. So when we get lonely, that shows that we want to love somebody and be around people. We want to allow patients to accept ambivalent feelings toward lost object or deceased, especially if person was suffering. If this person's suffering, we don't want them to suffer, but then when they die, we're sad. So we don't want them to die, but we don't. So we're kind of stuck between a rock and a hard place. We're ambivalent. Again, we don't want them to die because then we feel guilty, but then we don't want them to suffer. So again, ambivalence here. We want to encourage the patient to socialize even if they find it difficult. We've said it in the past. I've said it in the past. We are social animals. When people socialize, we release feel-good neurotransmitters. You have a good conversation with somebody, you feel better. You talk, you feel better. And that's the importance of a therapist. That's the importance of a good psychiatric nurse, that we listen to our patients, we validate what they're feeling, that they're not alone. We're here to guide them, because just the fact of having another human being hear you out is therapeutic. I had students that say sometimes in the past, we don't do anything as psychiatric nurses. And I said to them, did you listen to that patient while they talk? Yes, I did. You did something. No, if you don't have the results of doing a dressing change or something like that, but the fact of listening to someone's story is doing something. Okay, spend relaxed time with the person and don't be afraid to talk about deceased or dying process. Take the cue from the person if they want to talk. So just being around the person, this is called attentive presence. We're there attentively listening to the person. Okay, relaxed time and not being afraid to talk about the deceased. Now, if the person tells you, please don't talk about my son or daughter or father, I want to forget about that we have to take cues from them. So we don't want to force them to talk about their loss unless they want to. So we take cues from the patient. Allow for obsessional and repetitious discussion of the same topic. They may repeat things over and over. And this is rumination. This is a symptom of depression also, where they think things over and over and thinking it through, trying to figure out another way out of it. Okay. We want to assist the client to focus on the meaning of loss when appropriate. Okay. Now, some losses, losing a child at a very young age, it's difficult to find meaning there. When someone had a full, rich life and raised children, we can see meaning there. This patient is strengthening their ego. We want to focus on the patient's strengths. In other words, fortify parts of their ego that make them feel good about themselves. Allow patient to be in effective denial, provided they are slowly accepting the reality of loss. So we can't force them to speed through the grieving process. They have to go through their own pace. And the key here is slowly accepting the reality of the loss. Some people may lose a parent and be devastated. Other people may not be as devastated. Of course, that's an individual genetic thing, also how you grew up in childhood, and was your parents suffering? How old were they? Assist patient exploring and utilizing past effective coping behaviors. Maybe the person used to exercise or go to the movies or do other things. So we can assist them in exploring other ways to effectively cope. Allow patient enough personal space to grieve, but avoid abandoning the patient. So we want to give them enough personal space, but on the other hand, we don't want to abandon them. We want to let them know, I'm here should you ever want to talk about this. Okay. This patient to make sense of loss if possible. Again, losing a parent, an older parent, you can make sense of that. We're all going to die. Dad had a good life. When you lose a child at a very young age, it's harder to make sense of that. Let's talk about communication techniques that facilitate grieving. Again, broad openings. How are you doing today? Open-ended questions, very similar. And again, open-ended questions and broad openings allow the patient to take the lead. And in some sense, this is Freudian therapy. Freudian therapy would would just let the patient ramble and talk about whatever they wanted, open-ended questions. Encourage description of the situation. Ask if the person's talking about it, maybe ask them some details. Well, how did this happen? When did this happen? How do you feel about this? Things like that. Assist patient to translate and direct feelings appropriately. So we want them to direct anger appropriately, not to go beat somebody up, like, something like that. They're angry at the death of their son or father, whatever, so they're going to go beat somebody up on the street. That's not directing feelings appropriately. Allow patient to lead process. Go at the pace by observing for behavioral cues. Like, once again, the patient takes the lead. We are with the patient as they take the lead. Let's talk about predictors of dysfunctional grief. It's also known as complicated grief. In other words, this is heading toward depression. Poor premorbid functioning, such as low self-esteem, a previous psychiatric disorder, isolation or lack of social supports, substance abuse history, things like that. The death of a spouse or child is more apt to lead to dysfunctional grief. Untimely or multiple deaths where maybe your sister, mother, father, and brother are killed in a car accident. We have multiple deaths at once. That's more apt to lead you to dysfunctional depressive grief. Other concurrent life difficulties. If you're having other difficulties at work, at school, and things are just piling up, more apt to lead to a depressive dysfunctional grief. As opposed to if life is good in other areas and you have the loss of your father at 93, we can adjust to that probably more healthy. Death of a parent in childhood. So when a child loses a parent, that not always, can have effects on future depression and things like that. Might not have mentioned it. They used to say, psychologists many years ago would say it's, personality is all developed by experience, and the biologists say, no, it's all genetic. And maybe 20 years ago, they kind of said, oh, it's about 50-50. It's 50 genetics, 50 childhood experience. Well, about 15 years ago or so, there's a term called epigenetics, meaning on top of genetics. They've done studies, and we've talked about this before. They have now realized that environmental stressors can turn on and turn off genes. It doesn't change your genetic makeup. It turns on or turn off genes. And this may very well be what PTSD is, post-traumatic stress syndrome. Someone's in Vietnam and they're seeing horrific trauma, bullets are flying, and they turn on genes to release adrenaline, non-remitting, even when they're at night resting. They're in this constant state of hypervigilance and anxiety. Because it could be said that the environment turned on genes. Their genetic makeup has not changed, but the trauma that they saw activated certain genes. Okay. So death of a parent in childhood can very well turn on genes of stress hormones. Let's talk about successful resolution of grief. Patient mobilizing and engaging in spontaneous socialization. So they're mobilizing. They're going out little by little. When they were really sad, they were staying home. And maybe over a couple of weeks or a month or so, they're going out to the park. They're going out with their friends. They're demonstrating decreased anger. They're making plans for the future. They're verbalizing thoughts of deceased without excessive emotionality. They're returning to their premorbid level of functioning. Okay, I'm going to move on here. So we've gone through this rather quickly. Study the stages of Kubler-Ross. I could give you a question, give you a little scenario, a little vignette, and say, what stage is this person in? So know those stages, know dysfunctional grief, know what can cause dysfunctional grief, things like that. All right, I will be posting this in a day or two, and I will work on our last lecture in about a week. Okay, thank you, and let's say goodbye to Sigmund Freud. He's going to say goodbye to you. Bye-bye. Let's see if I can turn this off.